So first of all, welcome all of you to our talk on public health policy in action. More observant of you will notice I am not Warren Mabey, director of our school, who couldn't be here this afternoon, but will be here on the talk that is happening tonight. My name is David DiTomasi. I am a professor in the School of Business. That's my primary gig, but I also work here in the School of Policy Studies, teaching courses and working with Warren on some program developments for the students in the class who are about to choose your electives. I teach business, government, and the international economy in the spring, and I'll be hanging around at the end of the talk if you have any questions or interest in that course, and I can give you more detail on that then. But for now, I'd like to do our traditional welcome and a traditional introduction, reminding all of us that we acknowledge the Indigenous territory in which we have the privilege of meeting today. Queens is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. Before I introduce the speakers for today's talk, I also want to introduce the talk that is going to be given tonight between 5 and 6 o'clock p.m., I believe, in this room. Panel discussion, the Wuhan coronavirus, have the lessons learned from SARS helped? And the panelists for that discussion are going to be Dr. Gerald Evans, Chair of the Division of Infectious Diseases and Professor of Medicine at Queen's University. Dr. Samantha Budamer, Family Physician and Resident in Public Health and Preventative Medicine here at Queen's. Dr. Kieran Moore, Medical Officer of Health, Kingston Frontenac Lennox and Addington Health Unit, Professor of Emergency Medicine and Family Medicine, Queen's University. And Dr. David Walker, who Chair, Ontario Expert Panel on SARS and Infectious Disease Control, Professor of Emergency Medicine, Family Medicine, and Policy Studies, Queen's University. And of course, that event will also be live streamed for those who can't attend in person. There we go. But, there we go. I'd also now turn our attention to today's talk, and I'd like to introduce today Ms. Helen Cooper and Mr. Vincent DePaul. Catherine Donnelly cannot attend to today's talk. Helen, to my immediate right, holds a Bachelor of Science in Chemistry from Queen's and a Master's of Science in Econometrics from the London School of Economics. She was elected as a municipal councillor in 1980, then as King's first woman mayor from 1988 to 1993, also serving on the Queen's Board of Trustees. She then began a term as the chair of the Ontario Municipal Board and served as president of the Association of Municipalities of Ontario, as well as a member of the Premier's Council on Health Strategy on the Ontario Roundtable on Environment and the Economy. She's a distinguished fellow at the Queen's School of Policy Studies and president of Oasis Senior Supportive Living, Inc. Vince DePaul, to her right, is an assistant professor in the School of Rehabilitation Therapy at Queen's University here in Kingston. He did his physiotherapy training at Master University and has worked with older adults and individuals with neurological conditions in a variety of clinical environments. He completed his PhD in rehabilitation science at McMaster University and postdoctoral training at the Toronto Rehab Institute. His research focused on the development, testing, and translation of interventions that promote optimal mobility-related function in older adults and individuals with stroke and brain injury. So I'll just click that clue. The standard Slido instructions for those of you to ask Q&A. I believe the plan is to talk for about 30 minutes total. Then we will take questions from the audience. I will be walking around with this to give voice to the people asking the questions. You can use Slido.com or use the app on your phone or mobile device. If you're not, I would also, just as I always do, please silence all phones for the next hour if you can. Some people have trouble, but those watching via live stream can also participate, and we'll take a few questions from the audience. Please join me in welcoming Helen Cooper and Vincent DePaul.
Thank you. Thanks, everybody, very much. 2 years ago, approximately, I gave a presentation on Oasis, and some of you may go, well, why is she back again so soon? The reason being that a great deal has happened in the last 2 years that I think is worth talking about in terms of the knowledge I have certainly acquired and the excellent partnership now with the two professors at the Queen's School of Rehab, which was not the case previously. I'm going to take on the policy analysis perspective of this exercise. Vince is going to tell you the evaluation component. In other words, doing what we're doing, is it worth doing or not? It may feel good, but we'd like to extend beyond that. So I'm going to touch in the following areas. First of all, one of my favorite subjects is the Harvard Longitudinal study. We're going to look at the effects of loneliness, all of this very briefly. The results of the Public Health Agency of Canada, with which David would be very familiar, thanks to, well, I guess we can't thank SARS for too much, but as a result, we do have a new agency that's responsible for public health across the country. We need to know what's going on with the Ontario population for all of this to make sense. And we need to know what the Ontario government is doing. It's certainly in the last campaign, and the current government has made placed a great deal of emphasis on provision of long-term care. And we're going to show what we think is one alternative to long-term care provision that is decidedly less expensive and I think far more effective. So the Harvard Longitudinal study, I've put down the TED Talk reference. I recommend to everybody to take 12 minutes and 39 seconds out of your life to watch Ted Waldinger, who's the current director of the study, describe it. As far as I knew, it's unique in the world in terms of having survived for 80 years. Any researcher who's engaged in longitudinal work will know that that's extremely difficult to accomplish, that people disappear over time for one reason or another. It started with the class of 38 at Harvard, which was, as you would imagine, a rather select group. It included John Kennedy, and it expanded over the years to include wives and children, but also a population from South Boston who were not as privileged as the class of 38 at Harvard. And so they were trying to decide what leads to longevity. And Waldinger in that TED Talk will tell you, he's a lovely, engaging man, has some great quotes, which I've put down for you. And that is, the people who were most satisfied in their relationships at age 50 were the healthiest at age 80. In other words, the study started with looking at dimensions of people's skulls and whatever else, and it came to a conclusion as time wore on and they watched more and more people, that as I've written up there, a quote from Waldinger, good relationships don't just protect our bodies, they protect our brains. So I love his other quote, loneliness kills, it's as powerful as smoking or alcoholism, and take care of your body as though you're going to need it for 100 years. In other words, what he's saying is physical care is important, but it's a much broader concept of including people's psychological and social welfare. His predecessor was a chap called George Vaillant, if I'm not sure I'm pronouncing it correctly. But as he pointed out, as he said, nobody cared about these soft concepts of empathy or attachment when they started the study. Over time, they began to realize that these are extremely important, that people who age in a healthy fashion are people who have good, lasting, strong relationships with other people. The other thing, I put that second quote in, is if you've been really hard on yourself for a number of years, so they point out it's not irreversible, that you can, in middle age, develop attachments and friendships that will benefit you in the longer term. I looked at it's easy to find this stuff. It's all over the web. I looked up about a researcher in the States, again, another longitudinal study, a great as great a risk factor for early death as smoking 15 cigarettes a day is a lack of social connections. So you can see this repeating theme constantly. The UK government has formed a Minister for Loneliness. This isn't just directed to people who are older, but people who, I've put up the Canada's National Seniors Council as well. It's in the literature more about people who are older, simply because proportionately more older people are lonely. And why would that be? Well, less mobility, your spouse, your friends may have died, your children are living on the other side of the country. The list goes on of how people, as they age, are likely to be losing interpersonal connections and are hence more and more likely to be lonely. So the National Seniors Council reported relatively recently that half of those people they surveyed, over 80, reported feeling lonely. So what does that mean if you're a lonely senior? If you're living on your own, what it means is you're not going to work anymore. You don't have to be worrying or taking care of somebody else. You spend longer in bed in the morning. You don't bother getting dressed. You may start to feel, you watch soap operas on TV all afternoon. You may start to feel hungry, so you probably make a cup of tea and some toast. And so what happens? You get lonelier and lonelier. It's a downward spiral. And it's exacerbated by the fact you aren't eating properly, you aren't exercising. It all means bad news. So the Alzheimer's Awareness Month this month has a quote from there. We have made great strides in Alzheimer's research to date. We know that healthy lifestyle choices such as physical activity and healthy diet can help us maintain brain function, and in some cases reverse the decline. So, the Public Health Agency of Canada, which is relatively newly informed, why I've put it up is that it's talking about not only traditional disease prevention, but it is talking about promoting good physical and mental health and providing information to support informed decision making. In other words, recognizing much broader issues around determinants of health. And I just thought it was interesting that the latest, and Dr. Tam's getting quite a bit of airtime at the moment. She's on TV virtually every day with the coronavirus issue, that her annual report emphasized stigma. It was, i.e., who's stigmatized in our society not being able to access good health care as a result. So in other words, it's looking at a much broader concept of health than I think what most of us have traditionally thought of. So it has defined the social determinants of health, and I've listed them there for you. And why have I put red? Because Oasis, which is the example I'm going to talk to, I keep talking to people's backs over here. The example I'm going to cite for you is the Oasis project in Kingston. And I've put in red the components of the social determinants of health that Oasis is specifically directing. I don't know that we could manage all of them, but I think that's a fairly impressive list. Also, manna from heaven for me in terms of preparing slides. I had prepared my portion of the slide deck, and then along came John Ibbotson's article, so in went another slide. And this is what is really, really important, and I would say for the students who are interested in health policy careers, this is in Canada, this is something you really have to be focusing on, because it's going to consume a lot of your energy and efforts when you're working in health policy issues. We're a very, very rapidly aging society. And you can read that for yourself. You can see if we proceed in the direction we're going in now in terms of how we've traditionally dealt with aged people in our society, we're going to have to find a lot more money to deal with it. And we know there are huge competing interests. Education in Ontario is certainly one at the moment. And can you imagine the kind of trade-offs that we're trying to make between trying to take care of elderly and at the same time trying to make sure younger generations have a decent education and a decent university education. And I would say, as an older person, I have a vested interest in well-educated younger people as well, in terms of making life tolerable for me as I age. So here are the population facts. The average age of the population now is 41 years. Just a few years ago, it was 35. The fastest growing segment of the population are people over 90. And I think we can assume that people over 90 are going to need some kind of help. Maybe a little bit and maybe a lot. But they're a population that are dependent on others of us to continue to live a quality of life. Why is this? Because Canada had the largest, longest baby boom in the Western world. And so this is all entirely predictable. But somehow our systems can't deal with it. And so we're caught in this panic situation now of close to panic situation of how we manage care for elderly in our society. So that gives you bad news for the men in the room. Sorry to have to tell you that we women have a better chance of lasting longer than you do. That's still the case. Now, sorry, it got a bit foggy as I expanded it to put it on the slide. But I think these population pyramids are fantastic ways of showing people what's happening. You can see the baby boom. It's men on the left, women on the right. You can see how it's moving up, 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 up. And and you can see we are not replacing ourselves as a population. Birth rates fertility rates are very low. The only way our population isn't declining in this country is because of immigration. The Financial Accountability Officer has produced a report very recently that says there's a wait list for 35,000 individuals for long-term care. The provincial government has said it will build 15,000 new places over 5 years. And the cost of that, I've worked out roughly, is $177 per person per day. Once these new places are established, the wait list is projected at 36,900. An additional 55,000 new long-term places. I hate saying beds, right? I prefer to say places. Needed by 2030 to maintain this wait list. In other words, this wait list isn't going anywhere. Unless these new sites are developed, it's going to go way up. And of course, and I defer to Drs. Sinclair and Walker in the room who know far more about this than I do, but long-term care patients are occupying hospitals at a huge rate. And so the so-called hallway medicine in hospitals, which they will talk about in their spring course, I'm sure, we can't alleviate that because unless we literally kick people out. And so it's just going to get worse and worse. And I don't envy the current government because if you go back to their promises during the election, they are in no way going to be able to fulfill them. I would suggest whoever wrote their platform didn't know any of these things. So I'll finally get to Oasis. It's a description for you there. What we're doing is looking at naturally occurring retirement communities. In our case, most likely apartment buildings that people have naturally gravitated to. And they're not wealthy people, but they can afford a monthly rent. We have brought them together in a building with a private landlord, the original Oasis, as a Homestead Land Holdings building. Huge advantage in Kingston. Homestead owns so many properties, but Homestead also owns properties literally across the country. And they are huge supporters of this program as well. So it's a wonderful partnership of a landlord and a community volunteer group working together to create an environment for older people where they can continue to live happy, healthy, productive lives, where they're treated with respect, where their opinions and ideas are respected as well. And what do we offer them? We offer them fitness classes, outings. We offer 3 hot 3-course meals a week. We offer all kinds of morning coffee every day, a craft group, all the things that they have said they would like to do. We also have a coordinator, one person, one employee, who has developed a great deal of rapport individually with each of the members and who can offer health system navigation. She does not perform home care. We don't do anything of that. If any of our members require home care, they get it through the normal process that everybody else does. But with this very simple formula, I would suggest we're having extraordinary results. But that's why Vince's here. He's here to not let me get carried away. The last bullet is extremely important. We as a board, we're all people who don't live in the building. We consult every time we make a decision. We had a little bit of extra cash recently. We said to the members, how would you like to spend it? They came back to us and said, we'd like new chairs for the dining room. So we went and had enough money to get some new chairs. What I find is many of the members grew up in the Depression, and so they're extremely cost conscious, which is a good thing. So it started 11 years ago. I said it's as small as a volunteer organization can get, $130,000 a year, which is generous for what we do. And then that's why we have some extra money to buy new chairs. And we have now formed an alliance with Providence Care Hospital, which is, again, a hugely important thing for us. The program coordinator works for Providence. They manage our books, our finances for us. We have no human resource issues. And they're extremely supportive of what we're trying to do. And it's in their interests. We're stemming the flow into the hospital system. So I did the arithmetic. We currently have 48 members. It varies from time to time. And I figured out it's $10 per member per workday. So that's compared to $177 in long-term care. And there's our program coordinator, who is phenomenal. And she's stuck with the program all that time through all its ups and downs. And that explains to you what it requires to operate it. I just emphasize this is just one model. If you look at the literature, there are many ideas around co-op housing coming up and so on. But I think for the group of people in this population, this works extremely well. And I'm looking at the time, I gotta leave some time for Vince. Anecdotally, we had 2 deaths in November, one late 80s, one mid 90s. Both were in hospital for very, very short periods of time, and had been happily functioning in Oasis before that. We had one couple where the woman has had to go into long-term care for both mental and physical reasons. But the really interesting thing is that they're in their 90s. Her husband continues to live in his apartment. And so he can visit her during the day, but he comes back. He's well fed. He has people to talk to. It's making a huge difference to his personal well-being that he has this nurturing environment to return to, because his wife is very ill. We have a recent member within the last year who had been living on her own in an apartment in Toronto, and her family moved her to Kingston and moved her into this building. I've since talked to her daughter-in-law, who tells me that her mental acuity has increased dramatically, that she is a lawyer by profession, and her daughter-in-law said she was declining quite rapidly, but she said the transformation since she's come here and been active part of Oasis and eating properly means that she's improved dramatically. And I volunteer serve, so Catherine and I do on the meal on Thursdays, and I've got to know her quite well. I would never know that she had a dementia diagnosis. So, with that, I will turn this over to Vince.
Thank you. Great. Thank you for setting the table, Helen, so well. So you can understand why Catherine Donnelly and I were interested in partnering with the Oasis members and the Oasis board, including Helen. And this has been a very rewarding experience for us, and different in that it wasn't us trying to create a program for people to come to. It was tapping into something that actually has been shown to work, and just to provide some numbers to that. So this, Catherine and I connected with the Oasis group, but then we also brought in colleagues from McMaster and Western to achieve some of the objectives that we'll talk about. So the core philosophy of the research project, the evaluation, is really consistent with the core philosophy of Oasis itself. The empowerment of seniors to help make their own decisions and for their own lives, and it's a participatory approach. So as we're planning the research and doing the research, we're engaging the members throughout. We're using a mixed methods, which just quantitative numbers wouldn't be enough, and the qualitative stories wouldn't be enough, but together we think it does, again, will tell a strong story. So in terms of the objectives, our big objectives was to develop new Oasis communities beyond the Bowling Green site in Kingston. We've heard and we knew the success that had happened here, but we wanted to help demonstrate that this wasn't a fluke, and it wasn't just the nature of one Oasis coordinator or one strong group of people. So we wanted multiple sites. And also, while we're going along the path of developing and evaluating, to write a manual so other people can do the same to replicate this if it's shown to be effective. The evaluation component includes a number of outcomes, including that social connectedness is a primary thing we're looking at, but also we're including other health measures, including health utilization. So we're using ICES data to look at emerge visits, hospitalizations, eventual, for people who do need to go to long-term care, how many do, and also the time from when they're in the building to going to long-term care we're looking at. We will conduct a cost-benefit analysis of this, but on the back of an envelope, it seems very efficient, and create a sustainability plan. So we have a number of partners, including the academic partners and the Oasis itself. We've partnered with the Regional Health Authority, LIN, and or previously named LIN, and the Providence Care, Public Health in Kingston, and in the other communities we're in. Community agencies, a big part of this is leveraging existing resources, so not running all these programs and paying for all the services, but bringing in services that exist to meet the needs of the older adults. And the landlords are essential. So as Helen said, Homestead has been a supporter from the beginning, and didn't hesitate at all when we reached out about a site in London. But we also wanted, again, wanted to show that it is not just one generous landlord. It's a good idea across the board. And we've had very strong support from the CJM in Kingston, but also Effort Trust in Hamilton. Again, London is the Homestead, and we also have the City of Kingston. We have the Kingston Frontenac Housing Corporation is one of our sites. Kenron Estates, we'll talk about, is actually a mobile home park in between Belleville and Trenton. So I think I need to, can you switch to the next one? It's, that's the one we're on, Sophia.
Okay, next one.
Yeah. That one, yeah. So yeah, okay, perfect. Okay. Okay, so that first objective is to expand to other sites. So one of the big steps in that is, how do we identify the sites to expand to? So which NORCs, as Helen described, which naturally occurring retirement communities would we choose? So we first had to identify where the NORCs were. So we used Census Canada data to say where are pockets of where people over 65 is the cutoff we used, where there's a high density areas. And including buildings. Each building has their own postal code, so we can hone down to that level. Also, we wanted not just one type of population, so we had used the Ontario Marginalization Index to get a broad spectrum of marginalization levels. And then once we identified potential buildings, we actually just went to Google Maps and looked at the environment, the surrounding environment, what supports were in the area, what was the walkability in the area as well. So then we identified buildings, potential buildings or communities, and then we did basically cold calls. We would contact the landlord, see if we could see this physical space, because there had to have at least one common room to meet in. And that's not actually a given in every building. So that was a requirement. Landlord had to agree that we could use the space and not without a charge, because many of these common room spaces, if you live in one, to throw a party, you pay a certain amount per hour, so that's waived. And then resident interest was a key thing. So finally, the final buildings and communities we went with, we have 6 NORCs in 4 different cities. So Kingston has 3, which are 3 additional ones including in addition to Bowling Green, which are all apartment buildings. Quinte West is the mobile home park, which is a community, has 450 trailers, and many of these people have actually aged in place there. They moved in as young families and stayed. And then we have multi-building apartment building complexes in Hamilton and London as well. as I said, we have public and private housing, we have urban and rural, and again, different levels of marginalization. So at each site, again, we focused on 3 pillars, so the socialization, nutrition, and physical activity. So in terms of socialization, it ranges from just a drop-in coffee to actually organized crafts, and the group started their own games group, and all of the buildings have guest speakers. They have a speaker series where they invite people to come in, and advocacy. So many of the buildings have identified that they want to have their municipal councillor come in, and to address an area in the community or to make them aware of Oasis. And volunteerism. So many are volunteering in their own building, but also doing things for their community, fundraising or collecting bottle tabs or little can tabs to raise money for different organizations. So nutrition, all have some form of communal nutrition. So it's not just Meals on Wheels to their apartment building or through their apartment. It's some eating together. That ranges from sit-down catered meals to cooking themselves together, having potlucks. With where needed, we've engaged Loving Spoonful and food rescue programs to help them address meals on a budget. And physical activity ranges from the traditional exercises to line dancing. We have a very active line dancing group in the Quinte West site. So now, how we're evaluating. So again, we have both quantitative and qualitative measures. We've done interviews, which I'll give you some quotes, but then had some physical measures of their functional ability, falls, their nutritional status, and then that health utilization. Eventually, our intention is to follow these. Well, we are following them forward, and at 1 year, but beyond that, and do longitudinal work with these sites. But right now, what we can do is compare the original site to the new sites. And the new sites would be considered baseline, that the measurements that we're taking were before the programming was implemented. So we're going to show preliminary results, which are quite promising. So this is just, again, a really nice picture of what you'll find when you walk in. This is the Bowling Green site at coffee time. So, and just, again, the emphasis we're finding on when interviewing, they talk about this as an extension of their family. And many times their family there's many stories people have moved to be closer to family, and then family have to move on to somewhere else, and then this becomes their family. So from a measurement perspective, one of the primary tools we used for this is the loneliness scale, the UCL loneliness scale. So it's a very brief scale where if you score greater than 6, you'd be categorized as lonely. So when we looked at the original Oasis, there was only 6% of that group fell into that category of lonely, whereas in the new sites, 32% of the group were lonely. So the communal meals and nutrition. So again, this is a very, particularly at the Bowling Green, when we've engaged them to say, what are the key elements when we're rolling this out, and they are very invested and want to be clear, and the eating together is essential. So we looked at the level of nutrition. So again, the yellow being the original Oasis compared to the new sites, and in terms of people who have normal or high quality nutrition. So 65 sounds still like we should be looking at that, but it's in an older population, that would be probably where we would expect it at the high level. So physical activity. So we use self-report, and we have other measures of physical activity that we will, under longitudinal, actually measuring like a Fitbit activity that people are doing. So paying attention to the yellow, so looking at how many people, based on their self-report, were not active, so 13% in the original, and but in the baseline for the other sites, many more people were not active. So falls, as we all know, is a major health issue for older adults. In the group, the original group, that yellow was no fall, and very few people reported more than one fall. But we see there are fewer people with no falls and quite a significant number of people who had more than one fall in the new sites. So, and this isn't, we can't explain this just by age, because actually the original site has quite an older population. So this, even with a younger group, we're still finding that. So one of the things that Helen has talked about and alludes to is this averting long-term care, transitional long-term care, delaying or eliminating it, or making it not necessary at all. So using that $177 per day value, the cost for per person would be $64,000 a year. So in June, we weren't part of this work, but every patient in every resident in the Oasis was assessed as to whether they required long-term care or would be eligible, using the inter-RI data as an approach, and 12 were deemed eligible. So at that value, that's an annual savings, even considering the amount that it costs to run the program per year. So I just want to acknowledge, so Catherine Donnelly, of course, who is sorry that she couldn't be here, but the entire team from the 3 cities that we're working in, and we're meeting as a group tomorrow to talk about, again, how we sustain these and moving forward to other work related to it. So, and our funders, we received significant help from Baycrest in Toronto, the Center for Aging and Brain Health, the Ministry of Health and Long-Term Care, and the Ministry of Seniors and Accessibility. So, thank you.
Thanks, Vincent.
All right, well, thank you very quickly for those presentations and for raising the issues that you did. At this point, we're going to call up the questions that have been posed on Slido. I will walk around to the person who posed them and hand them this, and look forward to an effective Q&A.
Sorry.
Maybe someone doesn't have to wait.
It's a very quick question. How many members are enrolled in the different Oasis programs? Like how many is this one administrator?
Yeah, I'll check out. Am I still on here? I don't think I am.
Now this, if you like.
There. The Bowling Green 2 with the original site is 48 members currently. That varies for obvious reasons, give or take 50. Vince can answer about the other sites. The one site we haven't mentioned, the founder of Oasis in Kingston is a woman called Christine McMillan, who moved back to Toronto. She just celebrated her 90th birthday. She's living in a much larger apartment complex in Toronto now, and has started the Oasis concept where she is. Well, but there are over 400 units. I think there are 2 buildings, much bigger buildings. And Christine, being Christine, let nothing get in her way. Originally, just funny story, originally her landlord said sure they could use the common room, but they'd have to pay for it. Christine, it was a management company. Christine looked up who the owners were and discovered it was Power Corporation. And Paul Desmarais, she contacted Paul Desmarais directly and explained what she wanted to do. To do that, she also enlisted her MP, who's Carolyn Bennett, and a city councillor, Joss Matlow, And they petitioned Desmarais, and he said, this is a great idea. And he's now renovated the ground floor of one of the buildings to turn it into an Oasis site, free of charge. Why do the landlords like it? Because it lessens turnover in their buildings. Their tenants are responsible people who pay their rent, don't have wild parties, don't kick holes in the walls. It's enlightened self-interest for them as well.
So the other sites just are range, depending on the side of the community, size of the building, from about 25 to over 80 in terms of the numbers.
Yeah, one of the mobile home park site is very interesting because it's right on a boundary between Belleville and Trenton, and it's in the middle of nowhere, literally. I hope those who live in the area won't be offended by that, but it's not close to anywhere. And what Vince and Catherine have accomplished there is quite extraordinary in terms of people who've lived there for a long, long time, but never used the recreational facility, never knew their neighbors, and I gather it's changed quite markedly. And the other site that's also very interesting is the Kingston Frontenac housing site, in that these are social housing sites. So the folks there are of very limited income, and it's working really well there as well. So I think what Vince and Catherine have been able to show is that the model can work in a variety of circumstances for a variety of populations. I mean, one of the reasons it's saving money for government, of course, is people are still paying their own rent. But I would say that we're talking about folks who can't afford, we see these new lovely residential things popping up like the Riviera on Ontario Street, and the folks we're serving are not able to afford that kind of accommodation.
I think we had a question over here.
Thank you for your presentation. My question is related to 4 issues here with regard to your service. Number 1, what is the staff-client ratio in your facility? Number 2, what kind of training do you give your staff in order to provide the service for your clients? Number 3, what is the personal care for some of these clients that need it, especially if they have some disease or whatever, like dementia? And 4, how do you control for any spread of infections within this?
Oh, wow.
Speaking of which.
Okay.
Yeah.
So,
Yeah. Sorry, we'll have to go back one by one.
yeah,
Your first question was,
the training.
Staff ratio.
Or staff.
well, it's the original Bowling Green has one person who's a program coordinator. It's a Monday to Friday, 8:30 to 4:30 job. And these folks, they've got to know each other. If she takes a day off, they just, one of them has the key for the lounge and they open it up and make the coffee themselves. It's not a staffing situation, if I could put it that way. The person you saw her picture, Vince had it up. She's been through thick and thin on this. Her original qualification was as a PSW working for the VON. But when Providence Care took over the human resource component, because she doesn't work for us, she works for Providence Care, because we're just a group of 7 board members who we have no capacity to manage employees. So Providence does it for us. They did her proper job description, which she'd never had. And she's at a significantly higher level than what a PSW is paid for. It gets its pay, although we could argue PSWs don't get nearly enough for what they do. she's unique. She has developed an understanding. She understands privacy. Members will confide in her. The other component of this that is really important are family members. If you're living in Toronto and your mom is living in Kingston, you've made an arrangement with her that if she sees your mother not looking ill, she will contact family. So they know they don't have to be sitting on the edge of their chairs all the time worrying about what's happening to their elderly relative. In terms of, what was your next question? Oh, home care. We do not provide home care in any way, shape, or form. We're not qualified. And if somebody has had surgery, comes back in the normal course of events, they will get home care from the home care provider, the provincial home care provider, just like anybody else. And our program coordinator has a relationship with the home care office where she can also contact them and say, I think something's going on here that you better be aware of. And she has developed an excellent rapport. I'm a volunteer server for the meals. On Thursday nights, we have a caterer, a qualified caterer, who comes in with the meal. We adhere to safety regulations in food service. As far as any other disease control, it would be just like any other apartment building, right? If there's something going on in the building. The health unit would be involved in the same way.
Yeah. And I would just the only thing to add with the new sites, because of budget constraints, we've funded it. We're running it half-time coordinators rather than a full-time, and it's been interesting because it does definitely what Helen describes when the coordinator isn't there, people are getting together where they didn't before. So there is this spillover effect, and I would say they're not doing healthcare. It's more about connecting them with people who would do that for them.
There's another great story in one of the new buildings of a tenant who is deaf.
Yeah.
And she was encouraged to attend one of the initial opening meetings, i.e. saying to the tenants, some of whom had already petitioned to get an Oasis, but Vince and Catherine organized a meeting for the tenancy in general and said, would you like to do this? At her request, they arranged for a sign language interpreter. She came, she's become involved, she's teaching the other tenants sign language.
Okay, we have a question here.
Yeah, it's actually, I was interested in the top question there that was on the slide of page regarding, it was regarding intergenerational socialization. It says, has there been an intergenerational component of socialization in consideration with those Oasis, given the benefits to both younger and older adults?
So I think we haven't set out to do that as a core component, but in the new sites, and we have a high number of student volunteers who are interacting, and we've purposely done some things like that. So they've run, and this is maybe a bit stereotypical, but they've run tech kind of education sessions, one-to-one or group, where they will over months work with somebody how to use their phone and set things up and their tablet, and so that type of thing. But and then the meal volunteers, so that's where it's at. But we haven't specifically looked at that as a question. So.
Yeah, Vince and Catherine have used their students for various exercises in the building, and the tenants have loved that.
Absolutely.
But it's an area we haven't developed, and it's a really good question. I mean, it's another possibility. I know that our program coordinator on school break week brings her grandkids in who do a variety of things for the tenants, and they love seeing them. What we've learned is below a certain age, they get really tired. The members get really tired really quickly. They can't really deal with toddlers too well. But they love seeing kids sort of aged 9 and up.
This, just one last point about that. These are not age segregated buildings. That's the other,
Yeah.
So while there's a critical mass of older adults, there are other, there are families, young people, and sometimes people will come to events to support, but who, younger people who are in the building, but not as members, so.
I believe we had one over here.
Just to kind of build off that question, have you considered developing any relationships with high schools to get volunteers? I know I was a volunteer with my high school,
Yes.
and I had a fantastic experience with that, and that might also be something to consider doing research on.
Yes.
To further justify.
So absolutely. So we have, because volunteering is definitely a need for this, and we've gone different sources, including high schools knowing the 40 hours that they're required. So we have had some success. The challenge with that is sometimes, unless maybe yourself isn't included, but people leave after the 40 hours. So, but we have engaged some high schools, and we have a site in the West End, and that's where we've engaged them in some of the programming. So it's a great idea.
I'm just reading off the question up there. It's just for everyone, so you have term. What is the motivation for the private sector when that space could otherwise be monetized?
Well, I touched on that earlier. They have longer, good tenants. And most of those spaces aren't used most of the time. Bowling Green 2 has a lounge specifically dedicated to the use for members, that's where they have the morning coffee, and that's where Tina has her office. That had just been used for general storage, and they just cleared it out and painted it and all the rest of it. The much larger common room is where we serve meals, but the demand for the use of the common room isn't that great. And it's often Oasis member events that they organize themselves, like potlucks and Christmas party and New Year's Eve party and pancakes on Shrove Tuesday and whatever else comes along. They do their own volunteer appreciation event.
And this isn't necessarily for existing buildings, but we've spoken to the Homestead people, and one of the motivations that they've identified as a potential for landlords is a developer requires a community contribution. I guess every city has this requirement when you're going to build something. So connecting, we're dedicating this space, or at least opening the space for these services would be one motivation for, in addition to the ones that Helen has talked about.
Okay, we have time for one more, which I believe we have over here.
Right here.
Sorry.
A lot of these clients, the Oasis is a home for them, right? A home.
Well, absolutely. It's an apartment. It's a regular home.
It's a regular
yeah.
home. How do you deal with clients that are going home from the hospitalization? Do you have any kind of a procedure to help them getting over their hospitalization?
No, again, I'd be careful not. We're not professional medical practitioners, right? So in that regard, somebody coming home from hospital is if they were going back to an apartment that didn't have an Oasis, and could rely on the same kind of services like home care. We don't have any medical provision.
No. However, I think what we've heard is that people having a social network around them supports them in that way, not from a professional perspective, but the members check on each other. They have a system where they have a bag on the door, and they'll put a newspaper. They sort of share newspapers, and talking about thrifty. So they if somebody hasn't picked up that newspaper in the morning, then they know that there's a problem, and that's what happened with a woman who had fallen, and that one woman was found.
Yeah,
so
right.
so this support, but not from a health, that it still relies on the regular systems for that.
Okay, well, that takes us to noon. I wanted to, before I thank them officially, I also wanted to raise just a personal point. When I found out I was going to be asked to sort of moderate this, I found it very exciting and very personal. I'm kind of the sandwich generation. I've got 3 teenagers at home who are very demanding on the banking and transport sectors, if you can understand. But I also have aging parents. And who are in the coterie that we just were talking about. And if I knew that they were living in a place where they had socialization, had regular meals, and they had all the things that have just been talked about, the amount of stress that would alleviate for people like me, and just to be that confident, would be enormous. I don't know how you quantify it, but it certainly is no little thing. And for that, I would have to just say personally, thank you, and keep doing it, because a lot of second-order positive effects are being generated from it. So with that, thank you very much for your time, and here you go. Here's a little something from us. Don't put it on a flat screen.
Thank you very much.